Realize.
Okay. Good evening, everyone. Welcome to the IUSCRC PG Initiative Program with a Difference. This is the 108th episode of our this PG teaching, and today we are going a webinar on how to learn or how to interpret the color photos and the red-free photographs. And today's speaker is very dynamic and young person, Dr. Saeed. He is the senior consultant and head Vitreoretina department, Aravind Eye Hospital, Trivandrum. And our distinguished panelist for today's webinar is none other than the Guru Prasad Akshit sir. He is the teacher of the teachers. Sir is the director of Joshi Eye Hospital, Hubli. And another our panelists are Dr. Swapnil. He is the director for the Vitreoretina Services and Eye Center at Raipur. And Dr. Sandeep, he will join us shortly. He is from the Ajrekar Eye Hospital, Nagpur. With this, since we all are waiting for this important topic, I am going to invite our speaker for today's webinar, Dr. Saeed. Please kindly share your screen and start.
Sure. Thank you, Deepak, for your kind words, and I thank Team ARC for this wonderful opportunity. Slide. The topic for today's discussion is about color fundus photo slideshow. Are my slides visible?
Yes. And you are audible too. Please continue.
Yes. The topic for
visible, and you are audible.
Okay, sir. Thank you, sir. The topic for today's discussion is about color fundus photo, red-free photo, and fundus autofluorescence. These are non-invasive investigative modalities which helps us in the diagnosis and management of various causes of treatable and preventable blindness, like diabetic retinopathy, ARMD, ROP, etc. The color fundus photograph as such captures the images of the retina, optic nerve head, macula, retinal blood vessels, choroid, and the vitreous, and it's an important tool for documentation of clinical findings. Conventionally, we use fundus diagram to document findings.
Your internet.
Yeah, but these fundus diagrams are subjective and time-consuming, and not all details are mentioned, and it depends upon the skill of the observer. And one must be aware that you draw what you see. That means what you know, then what you know, that only will be recorded in the fundus diagram. Whereas when you take color fundus photograph, it's an objective evaluation of fundus. It is independent of observer, and it captures all the data which is available. One can go back and re-verify the findings then and there. Even after the patient went out also, you can re-verify your findings. It's less time consuming, but it comes at an additional cost of personnel and instrumentation. Historically, the first fundus photo was recorded by Jackman and Webster, and Carl Zeiss was the first fundus camera, which is available as early as 1926. But nowadays, a lot of advancement has happened, and we have a lot of non-magnetic cameras. Instead of film-based camera, we have digital imaging system, which can alter your, which can give a very high quality images. And we have SLO-based systems and ultra-wide field imaging, and we have integrated artificial intelligence with the fundus pictures, so that we can grade the diseases in a better manner. So the standard fundus photograph provides a high resolution images of the fundus, similar to what a practitioner observes during a fundus examination. These images replicates the true and natural colors of fundus without alteration. However, nowadays the commercially available equipments are equipped with various imaging modalities and filters that can change the color of the fundus to enhance the detection and diagnosis of specific pathologies. There are multiple protocols available. The three-field macular, the pathology dictates whether the photograph approach should image a magnified, highly detailed findings versus a wider field of view. for a more diffuse disease. Narrower field limits with a higher magnification. It yields optimal images for focal pathology like maculopathies, macular degeneration, optic nerve disorders, etc. Whereas broader field will be used for broader diseases. So the modified three-field standard photograph is used for studying macular degeneration like AR and etc. and optic nerve disease, etc. Whereas the seven-field photograph was used to treat the diabetic retinopathy, and this modified nine-field photograph was previously used to study the peripheral retinitis or like a disease like HIV retinopathy, uveitis, etc. But nowadays these are like replaced by your ultra field and wide field images. So conventionally, the standard photographs captures about 30 to 50-degree images, that is around the posterior pole, and one can get a steered image by altering the viewing angle so that you can get about 70-degree field of view with the conventional standard cameras. Nowadays, wide field and ultra wide field images is available. Wide field which covers about 60 to 100 degree. It is defined as a single captured retinal image which is centered on the fovea, and it extends beyond the posterior pole but posterior to the vortex vine ampulla in all the four quadrants. Whereas ultraviolet field can cover more than 100-degree and up to 200-degree. And in this case, the images are captured even anterior to the vortex vine ampulla in all four quadrants. So lot of cameras are available like Claris, Aptos, Nidec, Mirante, and all these have different degree field of view, and we can take a wide field with a single image or with a montage image also, and they are available with multiple filters to take autofluorescence image or red-free photo, or even FFA ICG are also integrated with your camera devices. And we have handheld devices like RedCam or Forus Neo camera, which with which we can take like pediatric wide field images also. So conventionally, this fundus photograph is used for mainly is used for documentation. Okay. No, the top one is not visible. Okay. Documentation, which is very important in medical, legal, and clinical aspects. It also used for diagnosing subtle lesions or ambiguous lesions. And by taking serial photograph, one can assess the progression and the response to treatment. In case of uncooperative patient, the fundus photo comes in handy to have a good detailed fundus examination. And another important application of your color fundus photograph is telemedicine, that is remote consultation. You can share the images through internet, and you can do a teleconsultation. And it's a very good tool to teach the patients. It means counseling the patient. When you describe the fundus finding to the patient, when you show the features through a color photograph, the patient will understand the disease in a better manner, and they can become very cooperative. And last but least, it is also very helpful tool for your research, and which is the ultimate aim of our medical profession also. So when in a given fundus photograph as a postgraduate student, you should identify, you have to describe this fundus photo in a systematic manner. So first of all, you have to identify which side, that is right eye or left eye. This is identified based on the normal thing like optic nerve head will always appear on the nasal side, and the macula appears on the temporal side, and the fovea is slightly lower to the horizontal raphe. Then you have to describe the media, whether it is clear or having any opacities. Then you have to describe the optic disc. Usually optic disc is vertically over, and then you have to comment about the optic like a neuroretinal rim. And the neuroretinal rim is thickness is identified with the mnemonic like ISNT rule, whereas inferior is thick, nasal is thicker, then superior and temporal are thinner. Then you have to comment about the vasculature, that is blood vessels, which normally bifurcates dichotomously, which shows a dichotomous branching, whereas arteries are narrower and veins are looking as a dull colored. And then you have to comment about the background retina, and finally you have to comment about the macula. So like in this case, the media is very hazy. It may be due to either asteroid halosis or due to corneal opacity. Like in this case, it is due to asteroid halosis. The first image on the left shows an asteroid halosis. Because of the total internal reflections, the image is very hazy in this. And sometimes vitreous hemorrhages can cause a hazy media. And when come to the optic nerve, you have to describe the color. Optic disc can be pale in case of optic atrophy due to ischemia, or the disc may be hyperemic in case of disc edema or like due to AA1 kind of thing, the disc will be hyperemic. In this case, the border will be like ill-defined, or sometimes you will see a subtle neovascularization like in case of NVD or optociliary shunt vessels in case of CRVO, that also can be picked up. And anomalies like optic dysplasia or megalocornea or either megalopapillae all can be picked up with your fundus photograph. And this tumors like melanocytoma, which appears as a subtle lesion, dark colored lesion in the optic nerve, that can be picked up very well with the optic with your color fundus photograph. So any abnormality in the disc, you have to describe first. And if the margins are blurred and if you lumpy bumpy appearance, then it's suggestive of optic nerve drusen, which will be like which can also be picked up by your fundus photograph. So you have to describe the optic nerve first. Then comes to the vasculature, and you have to see whether the all the vessels are seen properly. If there is any sclerosis or occlusion of the vessels, which may point out towards the diagnosis like CRAO, or sclerosed vessels, hemorrhages, or tortuous vessels can point out towards your central vein occlusion or ocular ischemic syndrome. And then if multiple hemorrhages and completely obscured vessels can point out your diagnosis like ischemic CR. Then we have to describe about the background retina. The standard 7-field fundus photograph is a very important tool for grading diabetic retinopathy. All the features of diabetic retinopathy like hard X-rays, soft X-rays, dot and dot hemorrhages can be picked up, and you have to grade or describe the fundus according to the features what you see. So NVE or NVD, pre-retinal hemorrhages, all you have to like identify, and you have to, based on the features available, you have to tell the diagnosis whether it is a like a proliferative disease or non-proliferative disease or vein occlusion. Based on the characteristic features, we can describe and identify. Sometimes you will get a lifted retina like this, and along with the tractional component. In this case, it points out towards a tractional retina detachment, or sometimes you will see a break with a bullous detachment. Then it points out to a bullous retina detachment. So background retina, you have to comment, and then you have to give a proper diagnosis. Then macular, you have to comment about the macula, whether it's attached, whether it is foveal reflex is present or not. Then fundus photo is very important tool in diagnosing macular diseases and assessing the following up, monitoring the treatment and assessing the progression of the disease. All these things, fundus photo is a very important tool. In this case, you can see the geographic atrophy, which is progressing gradually and it is increasing and involving the fovea. In tumors, the fundus photograph is color fundus photograph is a very important tool to identify the number of lesions, the size of the lesion, measuring the size of lesion and the location of the lesion, so that you can follow it up with the serial diagram. And after treatment, whether the lesion is resolved or increased, that can also be monitored with your fundus photograph. The left image shows the secondaries, and this shows the optic nerve, this shows melanoma, choroidal melanoma, and the choroidal melanoma with the serous detachment. And similarly, in vasculitis case, you can very well see a peripheral inflammation with a wide field photograph or montage photograph, and one can assess the treatment response with your series photograph. In this case, a series case of placoid choroidopathy with a serial photograph which is taken over a period of 1 month shows the disease is progressing gradually and started healing. And the photograph taken after 6 months shows that the disease is nicely healed up with the fovea spare. That explains the good visual prognosis in this case. Similarly, in peripheral retinal degeneration or breaks, you can identify the breaks, you can explain the patient very nicely, and the follow after doing lasers, you can very well explain to the patient about the treatment what you have done. And post-surgically also, you can document the fundus photograph pre and post treatment. That will help us to educate the patient in a better manner. Similarly, in pediatric diseases like ROP, so like a serial photograph, the contact ultra wide field fundus camera for neonatal eye examination has been used extensively for the diagnosis and follow-up of neonates at risk and with the suffering for ROP. And this is portable. This camera is a portable which can be used for telescreening as well. Though a lot of artifacts can be seen in fundus photography, sometimes you will get orange or bright crescent at the margin of the photo, which shows the illuminated iris. In this case, you have to change the angle so that you can take a better photograph. Sometimes eyelashes will have a hazy waves, If the camera is too far or near, then you can have a haze or loss of details. And similarly, a smudge in the system like will cause a repeatedly create a spot in the same area in all photos. So all this can be all this has to be kept in mind when you comment about the fundus photograph, color fundus photograph. Coming to the red-free photograph, red-free photograph, also known as monochromatic photograph, is based on the basic principle of two basic principles of light and photography. That is, use of contrast filters will alter the subject tones in black and white photograph, and similarly, the increased scattering of light occurs at shorter wavelength. So, by limiting the spectral range of illuminating source, the visibility of various fundus structures can be enhanced. This was used by Vogt in early 1925, and he used the green light to enhance the visual contrast of anatomical details of fundus, and he coined the term red-free photograph. So, to explain it, so when we use a panchromatic filter, panchromatic film or no filter, when you take a color fundus photograph, the black and white photo will be demonstrated in a varying shade of gray tones. But when you use a same color filter, that is a red color filter, the same color will be like appear lightened. Whereas when you use a complementary or contrasting color, the color will appear even darker. In this picture, the red image, when you use a red filter, it appears lighter, whereas the red image, when you use a blue or green filter, it appears darker. The same principle is applied in your red-free photograph, where we use a green filter, which enhances the contrast and which makes the red color structures appear very bright. So it gives the best contrast image in your thing. So the red-free photograph, also known as the monochromatic photo, here what we use is green light, which is absorbed by the blood and partially reflected by the retinal pigment epithelium. Because it is a higher wavelength, it causes less scattering compared to the blue wavelength, and it provides excellent contrast and best overall view of fundus. And it enhances the visibility of retinal vasculature and findings such as like dark red colored findings such as hemorrhages and also drusen's and X-rays are all very well augmented in this red-free photograph. So red-free photograph is commonly used in RNFL analysis. It's a gold standard for doing retinal nerve fiber layer analysis in glaucoma. And normally, RNL, the retinal nerve fiber layer follows a pattern that is bright, dark, bright pattern. When we from the superior to the inferior superior to inferior aspect area, the nerve fiber layer has a brighter spot in the superior aspect, a darker spot which correspond to the between the disc and the macula, and the inferior spot which appears a little bit brighter. And this spot is broader compared to the superior spot, which correspond to the ISNT rule. So when like in a localized nerve fiber layer defect occurs in a glaucoma, we'll see a wedge-shaped defect in the nerve fiber layer, which is very well appreciated in this red-free photograph, which with the wedge, the broader aspect occur in the periphery, and the apex is pointed towards the disc. Whereas in diffuse nerve fiber layer loss, that's the dark white, dark, the bright dark, the bright pattern is lost, and the entire nerve fiber layer appears as a dark area. And the other important application of red-free photo is in diabetic retinopathy. We are able to identify the blood vessels. We were able to identify the blood vessels in a better manner. So it can identify the neovascularization over the disc, neovascularization elsewhere, and intraretinal microvascular abnormalities are identified with the high contrast features with the help of this red-free photograph. So it helps in easier detection of advanced diabetic retinopathy, like early PDR can be very well picked up by your red-free photograph. Similarly, the superficial structures like ERM, the vitreoretinal interface abnormalities, can also be very well picked up by your red-free photograph because they appear as a contrast they appear as a contrast. Similarly, the macular hole edges can be very well highlighted by the differing contrast between this in the red-free photograph. And it also helps us in detecting the level of pigmented lesions. The lesions which are located below the RPE either diminish or disappear because the green light will not penetrate the choroid. So the lesions which are appearing below the RPE will diminish or disappear like nevus, whereas the lesion which are appearing above the RPE like a chippy will appear very prominent. Besides, another new recently published data is the in ROP, because it highlights us the blood vessels very nicely, and it is in ARP red free channel shows the enhanced visualization of retinal vessels. You can see the retinal vessels very nicely and the nice avascular area, and all these new vessels can also be very well picked up by your red free photograph. So red free photograph helps us to identify the subtle nuances, and it helps it plays an important role in identifying this. Now coming to the last thing, that is fundus autofluorescence. So fundus autofluorescence is another non-invasive imaging technique that detects the fluorophores which is present in the retina. So what are the fluorophores of substance which they are light sensitive molecule that emits fluorescence when they are stimulated by a light. Okay, what happens is when the fluorophore got excited by a excitation beam, they go to a higher excited state. When they come back to the resting ground state, they emit a photon of lower energy and a longer wavelength. So this principle is used in the autofluorescence. Here, the material fluorophore is present within the retina. That is, we are not injecting any external fluorophore. The fluorophore is present within the substance of the retina. So that's why it is known as autofluorescence. Fluorescence from the naturally occurring substance. And fundus autofluorescence is autofluorescence arises from within the retina. So we have multiple fluorophores which are available in the retina. Most the important one is lipofuscin. That is, which are the degraded vitamin A and metabolic byproducts of vitamin A, and this occurs predominantly in the RPE, and they have an excitation range of blue spectrum and the emission spectrum in the range of green. This is the primary fluorophore which is used in eliciting the fundus autofluorescence. Besides this, we have melanin, which is present in the RPE and choroid. This is excited by your near infrared lights. So it is the source of signal in your near infrared autofluorescence. We have a lot of other fluorophores like advanced glycation and glycation in products, oxidase, flavins, NADH, NADPH. All these things will have a little bit of source for creating fluorophores. And sometimes we will have abnormal accumulation of materials like porphyrins or crystalline deposits like tamoxifen crystals. All these BATS crystals, all these can also have sometimes produce drusense. All this can produce sometimes cause autofluorescence in your fundus. So basically in fundus autofluorescence, how the image appears, the fovea appears dark because the lutein pigments, the lutein and zeaxanthin pigment which is present in the macula absorbs the blue light, and so the fovea appears dark. Similarly, the disc appears dark because there is no lipofuscin in the disc, and the retina vessels appears dark because the blood absorbs the blue light, and the background retina you will have a grayish granular autofluorescence appearance. This reflects a healthy RP with a stable lipofuscin turnover. There is a difference between blue autofluorescence and near infrared autofluorescence. Here, blue autofluorescence is caused by, as already discussed, it is caused by your lipofuscin in RPE, which is stimulated by your blue light and emits a green yellow spectrum, whereas near infrared autofluorescence is stimulated by your near infrared laser, and it is caused by your melanin and melanolipofuscin in RPN and choroid. So the basic differences is blue autofluorescence, the fovea appears dark, whereas in near infrared autofluorescence, the fovea appears white. Why? It is because the macular pigments, as already told, the macular pigments absorbs the blue light, and it causes the foveal shadow in blue autofluorescence. Whereas the no pigment absorption means the fovea appears bright in near infrared because the melanin and the infrared light is not absorbed by your melanin or lipofuscin. So the fovea, in addition, the foveal RP has a high melanin, so strong foveal hyperfluorescence occurs in near infrared autofluorescence. And there is also a difference between your blue autofluorescence and green uh, blue autofluorescence and green autofluorescence. Here, blue autofluorescence, the macular pigments appears very pigment effect is high. The fovea appears dark. Here, the fovea appears little bit brighter, and the image contrast is very high for fine details, whereas it is little bit low for subtle lesions. And the blue autofluorescence is used for identifying Stargardts like positive pathology, whereas white field fundus autofluorescence uses the green autofluorescence. And media opacity affects blue autofluorescence, whereas the media opacity is not affected by green autofluorescence because it's a longer field. So how to differentiate these two black photographs? The FFA also looks black, and fundus autofluorescence also looks like a black and white photograph. In FFA, what you see is the source of fluorescence is external, that is exogenous, the fluorescent dye, which causes the fluorescence, and the dye lies within the blood vessels. So all the blood vessels will look brighter, the disc appears a little bit brighter. Whereas in fundus autofluorescence, the disc appears darker, the blood vessels appears darker. So this is how you differentiate between the FFA and fundus autofluorescence. Similarly, ICG and FFA also looks black and white, whereas in ICG we use the indocyanine green, which lies within the blood vessel, that is within the choroidal vessels also, because as the molecules are larger, they will not leak from the choroidal capillaries. So the choroidal vessels will be very well highlighted in ICG, whereas in fundus autofluorescence, you will not see the choroidal vessels, and the blood vessels will appear darker, and you will see a nice granular fluorescence. Similarly, the red photo is differentiated from fundus autofluorescence by the red photo appears, the fovea appears brighter, and the disc appears brighter in red-free photograph, whereas disc appears darker in fundus autofluorescence. And the red-free photograph will have a very high contrasting picture, and this granularity will not be present in the red-free photograph. So in fundus autofluorescence, we will describe the lesion similar to your FFA, whether hyperfluorescence or hypofluorescence we will describe. The hyperfluorescence can be caused by either increased accumulation of lipofuscin, like that happens in stressed RPE, or due to abnormal accumulation of excessive lipofuscin, like degraded photoreceptors, just in case of Best disease or CSR, or it may be due to loss of lutein or zeaxanthin pigments due to atrophy of the retina, just in case of a foveal telangiectasia. In that case also, you will get a little bit of hyperfluorescence. So these are the causes which can cause hyperfluorescence, like increased RP lipofuscin, like in case of lipofuscinopathies like Stargardt disease, or RP tear also cause the borders of the RP tear can cause hyperfluorescence. And subretinal accumulation of subretinal autofluorescence material like vitelliform dystrophies and CSR can cause increased hyperfluorescence. And window defect, loss of lutein or photopigment defect will cause hyperfluorescence. And accumulation of other autofluorescent material like drusen, astrocytic hematoma can also cause a hyperautofluorescence. What causes hypoautofluorescence is the loss of RP. If RP is not there due to RP atrophy, then will not have any will not have any lipofuscin to cause autofluorescence. Then in that case, you will have a hypoautofluorescence. Similarly, when the lipofuscin is not generated properly due to visual cycle inhibition, and just like in case of fundus albipunctatus, then also you will get a hypoautofluorescence. Similarly, something is blocking your normal fluorescence, like due to opacities or hemorrhages, then also you will get a hypoautofluorescence. So the lipofuscin, if reduced or absent RP, lipofuscin will cause a hypoautofluorescence, just like RP atrophy, RP tear, reduced visual cycle. Similarly, blockages from materials due to media opacities, macular pigments, hemorrhages also can cause a hypoautofluorescence. So fundus autofluorescence helps us in lot of diseases like degenerative disease, inflammatory diseases like mules, APMP, hereditary diseases, to identify the diagnosis and also the prognosticating of the diseases. So all these things, fundus autofluorescence plays a very important role. Let's see some of them. So in a geographic atrophy, fundus autofluorescence helps us in diagnosing it properly, because RP atrophy and consequent loss of intrinsic fluorophore, that is the lipofuscin, causes a extinguished FAF signal with a sharply demarcated borders. What is the major advantage of fundus autofluorescence is it can prognosticate the geographic atrophy based on the perilesional hyperfluorescence what you see. So sometimes the perilesional hyperautofluorescence pattern Based on that, we can prognosticate whether the geographic atrophy will progress slow or faster. If there is focal perilesional hyperfluorescence or none, then it indicates a slower progression, whereas banded or diffuse pattern like this indicates the geographic atrophy will progress very faster, whereas patchy, if you have a patchy autofluorescence loss, then it indicates the risk of progression to neovascular ARMD is higher. Similarly, in degenerative cases like in RP tear, it causes a because RP tear can occur in tall, large PED spontaneously or following consequence of your treatment like anti-VEGF, and it causes the loss of hypoautofluorescence, which is very well demarcated due to absence of RP at the edges. And at the edges, you will see a little bit of hyperfluorescence because of the rolled edges of the RP. And as the age progresses, there will be gradually overlapping, the gradually disappearance of this hypoautofluorescence occurs because of your remodeling and remodeling, because of your remodeling of the RP. Similarly, acute CSCR, most of the acute CSCR will see a hypoautofluorescence corresponding to the leakage in FFA because of the accumulation of fluid. And whereas in a little bit chronic CSCR, you will see a discrete hyperfluorescent autofluorescent spots, multiple hyperautofluorescent spot. This indicates degenerative photoreceptors, sometimes which will get deposited down also. Whereas in very chronic CSCR, you will see a gravitational tract sign corresponding to the sequelae, which shows that the RPEs in this area is degenerate. And another important application of fundus autofluorescence is your HCQ toxicity. It can pick up HCQ toxicity before your, sometimes it can precede the thinning and STOCT. The earliest sign is pericentral ring of increased fundus autofluorescence. As the toxicity increases, you will see mottled loss of fundus autofluorescence. As the severity increases, you will see a complete loss of fundus autofluorescence with increased fundus autofluorescence in the peripheral adjacent area. In MACTEL, what we see is a hyperautofluorescence because of the atrophy of the lutein. Because of the atrophy of the retina, there will be loss of lutein and zeaxanthin. And what we see is the hyperfluorescence area because of the excessive reflections from the underlying RP, which become visible, which causes the hyperautofluorescence. Similarly, in Stargardt's disease, fundus autofluorescence plays a role. All these flecks will appear as hyperautofluorescence spots because they all have a excessive lipofuscin accumulation in that flex. And the flecks radiate outwards from the center. And as age progresses, the flecks fade and they become less hypoautofluorescent because of the transition of to RP death or atrophy. In advanced disease, RP death and atrophy occurs, so it causes the flecks to fade away or become hypoautofluorescence. Similarly, another important application is the Best disease, where you will see a different fundus autofluorescence pattern based on the stage of the disease. In like the shed photoreceptors, debris and lipofuscin accumulates in the subretinal space, causing the bilateral egg yolk-like lesion in this Best disease. In previtiliform stage, there is no autofluorescence, whereas in vitiliform stage, we will have a very nicely, sharply demarcated homogeneous hyperautofluorescence will be seen at the level of macula. Whereas in pseudohypopyon stage, you will see a gravitational layer of hyperautofluorescence, settling under a isoautofluorescent area. And in vitello-eruptive stages, it shows a dark lesion surrounded by a hyperautofluorescence, bordered by a condensation of hypoautofluorescent material. Whereas in atrophic stage, that is fibrotic stage, it will be characterized by a absence or diffused or decreased signal due to atrophy of the choroid. And another important application of fundus autofluorescence is in choroideremia, whereas it is characterized by a bilateral mid-peripheral zone of absent autofluorescence, which correspond to the complete absence of RP because of the chorioretinal atrophy. And with the nice scalloped, lobulated, preserved central area. As the disease progresses, the central area can also will get damaged. This central area will appear autofluorescence, whereas rest of the area will have a loss of autofluorescence. And fundus autofluorescence is an accurate structural marker that correlates with visual acuity. If this area is preserved, the visual acuity will be better, and also helps us in identifying the candidate for a gene therapy. Another important application is the Robson-Holden ring, which is seen in retinitis pigmentosa patient. It's not seen in a normal normal color fundus photograph, whereas the autofluorescence show a nice ring, annular hyper autofluorescence ring, which encircles the macula, which demarcates the healthy retina from the affected retina. So as the disease progresses, the extent and the size of the ring correlates strongly with the disease severity and progression rate. As the disease progresses, the ring constricts towards the fovea. Initially, the ring will be bigger. As the disease progresses, the rings can constrict towards the center of the fovea. And besides, in inflammatory conditions like serpiginous choroiditis, fundus autofluorescence helps us in identifying whether the lesion is active or not. The edges of the active lesions will be like showing a hyperautofluorescence with a surrounding halo. As the inflammation subsides, the hyperautofluorescence lesions become hypoautofluorescence. Similarly, in other inflammatory diseases like MEWS, multiple hyperautofluorescence dots will be seen, which correlates with the white dots seen on fundoscopy. In APMP, you can see a hypo and surrounded hyperautofluorescence, whereas in birdshot chorioretinopathy, you will see a multiple hypo AF spots with a peripapillary confluent hypoautofluorescence spot. And in azure, its characteristic trizonal pattern is seen, characterized by the normal periphery and the area of speckled fluorescence which border the affected area, and central confluent hypoautofluorescence, denoting the RB which has been atrophied. So there are a lot of artifacts which can occur in autofluorescence also, like media opacities like cataract and corneal scars or vitreous opacities can reduce the fundus autofluorescence signal, causing generalized hypoautofluorescence or focal area of hypoautofluorescence. So one has to be keep in mind all these things. And similarly, poor fixation or motion artifact can also cause blurring or duplication of structures, impacting accurate delineation lesions. Similarly, similar to fundus photograph, eyelashes and eyelid artifact can also occur. And the variation of image acquisition settings like exposure gain, all this can also affect the quality of your picture, what you get in fundus autofluorescence. Similarly, far periphery can appear dimmer due to vignetting, and undilated pupil will cause a shadowing like in any other fundus autofluorescence. So to conclude, these fundus autofluorescence, color photo and your red tree photo, they are all non-invasive and sensitive imaging modality. Fundus photo helps us in documentation, monitoring, and it's a very important tool in telescreening, and it's another important tool in counseling and educating the patient. Whereas red tree photograph is the gold standard for doing retinal nerve fiber analysis and for diagnosing diabetic retinopathy and other diseases in an early manner. Whereas fundus autofluorescence provides a metabolic map. The active or degenerative epithelium RPE will be denoted very well with your fundus autofluorescence. So it is helpful in early detection and assessment and prognosis of various degenerative and inflammatory conditions. But all these investigations should be interpreted with other clinical data, and a thorough clinical examination is always a must, including patient history and comprehensive examination finding, to help us in an accurate diagnosis and managing the patient. Thank you for your patience, and this forum is open for discussion. Thank you.
Thank you so much, Dr. Said.
Yeah.
Illustrative, just like an encyclopedia on all the three topics.
Yeah.
First of all, I will come to the Dr. Guru Prasad sir.
Yeah.
And you have a huge experience of all these things. Means whatever the things are available in the retina or the gadgets, you have everything and you have worked a lot on it. So how useful you find out these rates?
Yeah. Now,
Uh,
first of all, congratulations, Dr. Syed, for covering such a vast topic of three different imaging modalities in such a short time of 40 minutes. We have 20 minutes for discussion, which is good enough.
yes, sir.
Now, coming to my experience with cameras, let me start with the color photos. We have both the Optos and the Claris. We did have the um, Topcon TRC 50 VT in the beginning and later followed by 50 DX. And they were giving good pictures of the central 45 degrees, and they were good for the macula and the disc. And really good resolution was available with those pictures, but it was limited. Now with the Optos, especially with the Optos and the Claris also to some extent, the image is definitely ultra wide field. With the Claris, it's about 150 and it's about 200 with the Optos. But not only do we get a broader field of view, there are some disadvantages. I'll tell you if you want, if there is time. But there's definitely a broader field of view, and not only the broader field of view, but the best part is it is a non-mydriatic camera. Without dilatation of the pupil, we are able to see the entire retina up to the say a little beyond the equator, may not be up to the ora serrata. And even through cataracts, it is possible to see the retina, even with the non-dilated pupil and the cataract. And another very good feature of these fundus cameras today is the ability to zoom the image and find out flat neovascularizations, which are very, very important, not to be missed in diabetic retinopathy. In proliferative diabetic retinopathy, we tend to miss sometimes with indirect ophthalmoscopy flat neovascularizations, which can be easily documented. And by zooming in, we are able to see these flat neovascularizations, which are very, very important in the decision making for the treatment. I think with this ultra wide field imaging, it is possible to do a better job, come to a better decision about the treatment to the patient, and we can do justice to the patient in many situations. Coming to red free, I think, would you like me to continue or would you like to pass on
Yes, sir.
this?
Yes, sir. Please, 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 sir.
So I think one thing which probably is very useful in red free is, of course, apart from all that was covered beautifully by Dr. Syed, the RNFL loss can be easily determined in glaucoma patients. But more important than that, in patients in childhood blindness, in children with low vision who come to you for fundoscopy, if you see with the red free, you can pick up the fundus may appear normal, but when you see with the red free, you can pick up RNFL loss. So this is an important sign which will help you to tell that the patient has got either delayed visual maturation or LCA, some such congenital optic atrophy, which sometimes doesn't have a treatment. The prognosis is not good, and definitely helps you to guide the patient to refer the patient to a pediatric neurologist. So RNFL loss seen on red free imaging in a child with low vision is definitely one feature which we can tell about in the red free. FAF autofluorescence, I think he mentioned beautifully about the geographic atrophy. There are different types, the banded and the patchy and the banded type, which have a poor prognosis. RP tear is something that which can be a spotter in the exam. I think there are a lot of students who are going to benefit from this, at least if not live, they can probably see this presentation later on YouTube. CSR, definitely it has a very big role to play in knowing whether it is atrophic or whether it is active. Uh, HCQ, I think he did show some images about HCQ toxicity. And I think in the Caucasian population, it is different from the Indian population. In the Indian population, which we get almost one every month or two every month for screening for HCQ toxicity for patients on treatment with HCQ on rheumatoid arthritis for rheumatoid arthritis, we see a different type of pattern. A parafoveal hypofluorescence is seen, which is not a complete ring. So I think that we have to keep in mind. It should not be mistaken for some other pathology. And these are also um, part of executive toxicity. Dystrophies, I think Stargardt disease he mentioned very well. Stargardt disease, one peculiar finding which the exam going students should know is the peripapillary sparing. The flecks which are seen as hyperautofluorescent spots, or the flecks that are seen as hyperautofluorescent streaks, are not present around the disc. So this peripapillary sparing is, I think, important to diagnose. It is pathognomonic of Stargardt disease. The other thing is acquired vitelliform lesions, which can be easily picked up on. Sometimes there is a subretinal accumulation of material, which can sometimes be passed off as SREM, but there won't be any CNVM. There won't be any cause for the STEM, which we can SREM, which we can attribute to. And these are the cases which we can subject to the test of FAF and come to a diagnosis of hyperautofluorescence due to AVL. I think one last point about the Robson-Holder ring in RP. I would like to say that I'd like to tell the students who will probably join in later. I think now there are only about 8 participants, but then later on when they see this presentation, they will probably learn RHR, that is the Robson-Holder ring seen in RP. The periphery is hypoautofluorescent. The center is hypoautofluorescent, but there is a ring of hyperautofluorescence. Why there is hyperautofluorescence at the ring area and not at the posterior pole? So the reason is that the photoreceptors are lost, which initially unmask the hyperautofluorescence of the RPE, the lipofusion in the periphery, and later on there is a consecutive RPE loss, and that leads to hypoautofluorescence. So there is hypoautofluorescence in the periphery, but at the ring area, it is still the RPE is still active. Only the photoreceptors are lost. That is why we see that the photoreceptors which are lost are unmasking the normal RPE and the lipofusion, which is the cause for the ring. So I think this is a concept which the students should know in case they are asked. This Robson-Holder ring, if the examiner catches them, it can go on and on. The discussion can go on and on. So I think one more thing is the serial testing that has to be done over years. Every year, one fundus autofluorescence test has to be done in order to know the progression of RP. I think that is about RHR. Thank you for this opportunity, Dr. Deepak. Anything else I would love to answer? Let us hear from the other panelists as well.
Sure, sir. Yeah. Dr. Swapnil, your views on first on Dr. Said talk, and if you'd like to add something.
Yeah, so Dr. Said actually gave a very elaborate talk, and Ajit sir already have given more insight in this. I just wanted to highlight few things. It has already been told. So whenever residents are getting any image, fundus, color fundus image or any image, so I think it is the sequence which they need to follow so that they do not miss on any of the things. Like as Dr. Sayed had mentioned, first you need to mention, this is again, I am repeating because this is, I think, important. Side, then how is the media, then coming to the optic disc, blood vessels, macula and periphery. If they go on to follow this sequence, they will not miss a single finding in the fundus picture. Secondly, it is important for residents to comment on the foveal reflex, whether it is present or absent, and if it is absent, then elaborate on the findings. Then many of the times I find residents being confused when they are handed over the image, whether it is red-free. Though we know that it is this, but when in exam, sometimes we are not able to exactly identify whether it is a red-free picture or of autofluorescence. So in red-free picture, the disc appears white, blood vessels appear dark. Whereas in autofluorescence, disc and blood vessels both are dark. And in angiography, the blood vessels are bright. So if they have these 2-3 points, they will not confuse between the red-free picture, autofluorescence, and fundus angiography. Then coming to autofluorescence, I just wanted to highlight the importance of autofluorescence in disc drusen. Sometimes we get this disc edema and then we diagnose them as AION or optic neuritis and then subject these patients to investigation. So if this is autofluorescence, a very simple test which can help us in diagnosis this disc drusen, which appears as hyperautofluorescence over the disc. And coming to choroiditis, so before we used to do fundus fluorescence angiography to find out whether the lesions are active or healed. But this autofluorescence is non-invasive. Whenever there is activity, it will show as hyperautofluorescence. And if the lesions are healed, then it will show hypoautofluorescence. So active is hyper and healed is hypoautofluorescence. And lastly, coming to significance of prognosticating in ARMD especially, because in wet ARMD we usually gives multiple anti-VEGF injection, though we usually don't see the fluid there, but still patient is has deteriorating of vision. So if we go on to analyzing serious autofluorescence images, so we can see that geographic atrophy is also the cause which is causing this loss of the vision. So we can actually explain the patient that this is the reason why patient has not much improvement or the vision is deteriorating. Apart from this, I think most of the things are covered by Dr. Syed, and Aichit sir has already elaborated on that.
Very true, Dr. Swapnil. What you said means first thing is for anyone to comment on this is go by the order, means which we have to take first and which have to take last. And if we follow the order, then most of the things it will be in the same plane and other thing. Dr. Sandeep, I think.
Yes, sir.
Yeah.
Yeah,
So,
it's very nice presentation actually by Dr. Sayed. Really impressive and very elaborated. And the rest of the thing, I think Dr. Aichit sir has taken into very deep. And so Swapnil was the topping over the cake. So I think there is nothing more to say about all those things. But I know and I think that we need to study more of fundus autofluorescence because in future, it's a future actually. We are not. I think most of our older senior consultants are not that much in fundus autofluorescence, but I think most of them will get into it right now. As what we see as a fundus photo and red free are with everyone, but fundus autofluorescence, I think it's a new way to learn for most of the senior consultants as well as me also. I learned a lot through today's discussion. Thank you, Syed, Dr. Syed, for this thing, and thank you, sir, Aichit sir, and Mishra sir for all the opportunity and taking me in this team also for getting a good experience. Also, I think I'm getting the experience rather than I would be rather be a PG student rather than being a consultant or over the other side. And I thanks for this very beautiful presentation, lovely presentation. Yeah, I think
Guru
there is a
sir,
long way to go for fundus autofluorescence. I
Just
know.
wanted
yes.
to add that infrared is basically for vitreoretinal interface, whereas autofluorescence is mainly to see the health of the RPs.
Oh,
Yes, sure.
Guru Prasad sir, one final comments from your side after
No, I
anything
just
you'd like
want
to.
to thank us, Dr. Swapnil, for adding this drusen, in the indications for autofluorescence. Yes, it is one of the easiest and simplest tests to distinguish between pseudo papilledema and true papilledema. I think when we are confused whether the disc is really elevated or not, and we do a simple V scan or autofluorescence, we will be able to pick up this drusen, and we can save the patient for at least 10,000 rupees for which you would be spending on an MRI brain. I think that is one important thing. And one thing more I would like to add, I just remember that there is one condition called autosomal recessive breast disease, AR breast, which has these vitaliform lesions in the form of blisters all over the retina, not just at the macula, but all over the retina. And that can be picked up very well on autofluorescence. Although the ERG and EOG may not be typical of West disease, the autofluorescence comes to a rescue, and we can make a diagnosis of AR-BES based on hyperautofluorescence of these blisters. I think there is one thing that we can add. Apart from that, I think everything else is covered. Yeah.
Yes, sir.
I would like
So-
to ask a question. Like you might have seen our old fundus cameras with a nice magnified macula images, and now you are seeing ultra wide field images. So, which you feel is more informative, that older cameras or newer one? More
Whom are
informative.
you asking?
You are saying. Okay, yourself.
See, I have used Topcon TRC 50VT, the oldest camera we had, which I think we got it in 1980s, late 80s, and then we upgraded to the DX50, which we still have. We are using it for some study. I think the image that we get with Optos, I would say Optos because Clarus also gives good images. In fact, true color images, but the field is restricted slightly. Not the wow effect is not that much, whereas with Optos it is really great. And even after zooming, we are able to get a good amount of resolution. With high zooming also, the disc details, the retinal details, the vascular details, and as I said, the NV flat NVEs of diabetic retinopathy that we can miss on simple clinical examination is something that is a very important feature of the wide-angle fundus photography. I think I would say we are definitely progressing. I would say the older cameras may become obsolete very soon, but if people are still using it, definitely there is a lot to learn from the captured images, because the resolution is quite good. You can't zoom. You can zoom a little bit, but you can't zoom that much, and you can't see the periphery at all. With a montage image, you can probably gain up to 66, 65, 70% max, but then that is not enough for in diabetic retinopathy is a mid-peripheral disease. And our country is full of diabetic patients and diabetic retinopathy disease. So we need to have wide field cameras, at least the Clarus, if not the Optos.
Thank you, sir. So now our time is also going to finish. First of all, I would like to thank Dr. Syed for such an illustrative talk that everyone, even all the experts have their idea, means they learn a lot from your talk. And for the residents, it's just like a blessing, because such type of webinars or the topics are usually not as such covered or available everywhere. Means you can get a number of books on the NGOCTs or FFA or other thing, but such a topic means how to go and how to follow these things, means read photographs and other thing. Thank you, Dr. Said, for such an illustrative talk. And Guru Prasad sir, as usual, I'm your big fan, and you have added all the things, all the points, what are the things which are necessaries for the PGs to know, not only from the exam point of view, but in the future too. As Dr. Swapnil and Dr. Sandeep both said, our expert, that it is now the future, means maybe after 4 or 5 years or 1 decade, this fundus-free photograph or autofluorescence of the fundus will be one of the major investigation, and it will replace or not, if not replace, then at least included as an adjacent investigation for each and everything. So with these words, I would like to thank everyone from the whole team of EIVS ARC. And for the viewers, you can watch this webinar. Guru Prasad sir already mentioned that it is available on EIVS One EIVS network. And anytime those who missed the webinar or want to repeat, they can go and watch it as much time as there. And thank you our IT teams, Sunil and Tushar, for coordinating each and everyone. Thank you, everyone. Good night, sir. Good night, sir.
Thank you,
Good
sir.
night.
Thank you.
Thank
Good
you.
night.
Thank you, sir.
Thank you.
Right,
Thank you.
Deepak, Sandeep,
Thank you, sir.
Swapnil, and Syed.
Thank you, sir. Thank you.
Thank you. Thank you.
Good night.